Scott couldn't be here this morning, but we have Stuart here. And Stuart, can you just tell us a little bit about yourself?
Yeah, sure. So my name's Stuart. I use they, them. I'm the founder and chief exec of This, which is the UK's LGBT cancer charity. And I'm a CML patient, so that's chronic myeloid leukemia. I was diagnosed about 3.5, 4 years ago, something like that. And I get treated in Kings in Southeast, and I try and talk about these topics as much as humanly possible.
I'm so happy that you're here. And we really want to hear questions from you. So feel free to unmute yourself and chime in. Like, this is a lovely small group for us. Or use the chat. Oh, I've already got a question. We've got someone else coming in the room as well. So from Claire, thanks for a great session. What would be your top 3 tips for people working in cancer services to make it the best experience possible? So actually, let's start with Stuart for this.
So I think the first thing is taking a good evaluation of your current service and understanding why it's built the way it is. So cancer services tend to be very bimodal in the way they're gendered, and it's very like, this is the men's group, this is the women's group. And sometimes you have to look at it and think, why are we doing it this way? Why can't people mix? Sure, sometimes there's going to be tumor specific things, but at the same time, that should still be trans inclusive. So really, we need to shake things up about the way that we're actually creating our services. And then the other thing as well is understanding that at the moment, what tends to happen is because there's a lack of provision for LGBTIQ+ patients, what we're expecting them to do is to sort of push for themselves, to be seen, to access services, to come to you. And the reality is if you are in a position of power within your service, it's about reaching first and acknowledging that if you've never done anything before, why would people be coming to you consistently? So it's up to you to be visible about the work you're doing, be honest, have good humility about the fact that you're growing and learning, and really making as many links into the community as possible, especially if you're able to do anything like co-production, so you can actually work with the community, learn the language, learn your fluency around our concepts, and then make sure that you can be the best healthcare service you can be.
Cool, I love those. Yeah, because I think there is something about that kind of the setting the scene that then makes you be able to kind of bring your questions. And I think one of the things I mentioned was my doctor outing his nurse, like, and that was his kind of way of like, okay, it's okay, whatever you say, whoever your partner is, it's totally fine. Thank you so much, Claire. And if you have any other questions or follow-ups, like I said, I think Matthew, you came in after I said it. Feel free to unmute, feel free to join in the chat, or write your questions however you want to do it. But one of the things I really wanted to ask you, Stuart, in particular, was actually around sex, because one of the things that Scott just brought up was the lack of knowledge around oncology, especially from Scott's position, was talking about, PrEP and gay men having sex, and, that lack of knowledge actually, if someone doesn't feel comfortable enough to ask questions, that thing of like, if the environment isn't there, then if someone's feeling like they just don't want to deal with it, could they possibly take PrEP or do something that could actually be detrimental to them during that time because they haven't told their doctors because there wasn't a space for it? Have you heard about situations like that before?
Yeah, me. So I've had exactly the same kind of conversations where I've said to my clinician, especially because I have a blood cancer, and I'm on treatment for life, all of that stuff. I'm like, how's this work? And there's always, I think there is a 2-factor answer when it comes to clinicians. There's the clinically sound answer, whereas, PrEP is a relatively new drug. People are still thinking about how it works with the body. Drug interactions are probably not known. But then there is also, you can go a bit further and you can think about likely interactions, and PrEP should be safe. But then you also have the other point is treating the person as a whole. and understanding their reasons for taking PrEP, their life, well, what's the motivation, and actually engaging with talking about sex with them and discussing with them, actually, you know, maybe I'll take a look into that. Maybe I'll go speak to the sexual health center and figure out what's going on. And then also discussing other options. Okay, if PrEP's not possible, let's discuss barrier methods, let's discuss other things, because it's just not appropriate nor valid to tell people I don't know or go look online, which is what I was told, because the information isn't there. And if the information is there, sometimes you're not sure how valid the source is. So really, who's going to know best other than your oncologist? And in my view, it's their responsibility to see your questions through to the end. And if they don't know an answer, they're the best person to understand the best possible answer. So it's their ability to go away, although I understand they're very stressed and they have lots of time management issues, etc. But when you have a really good question like that, which is also protecting your health, the reason we take PrEP is to protect our health and to have a good idea of social cohesion and responsibility in our community to try and stop HIV. So it's a really good thing to be taking. So I think it's entirely valid to basically push your clinician and say, you know, what is the reasons here? Can you figure it out further? Because especially if you don't have any of that knowledge on the specifics of how the drugs interact, why would you be expected to go away and figure it out for yourself? It just seems completely inappropriate.
Yeah. And do you have any thoughts on that, Angie?
Yeah, I mean, I think so. Like, the general point is that they should ask more questions. I mean, I think in terms of inclusivity, the best model I've seen in healthcare is in sexual health clinics, because they ask you, what kind of things do you do? What sorts of people do you have sex with? They don't assume, you know, that you must be having a particular type of sex with a particular gender of person. They ask you, and then based on your answers, then they'll work with you to be like, okay, what tests do you need? What contraception might you need? And so on and so forth. And I think it's a lot of it is just about asking people and not making assumptions. You know, and obviously part of that is making your whole service and you specifically as a clinician feel safe to discuss those things openly, which, I mean, like, it should be, but I think we all know that it isn't always, or it doesn't feel always like that. So I think, yeah, a lot of it is just about, it does have to come from them, because, you know, very often, you know, if you're an LGBTQ person, you know, you have very likely faced discrimination at some point, and you're going, okay, I just want to get the best treatment I can. Maybe I will shut up about being gay or trans or whatever, just so I can get through this really stressful part of my life. And you shouldn't have to, but sometimes you feel that you do need to.
Yeah, and I think that thing about, you know, we're not coming into this blank slate. Like, we've all heard misinformation before, or, you know, I know for myself going in for, you know, a woman's, you know, exam, and being told that I didn't need that, you know, but they didn't ask me, did I used to sleep with men? Like, maybe my current partner is a woman, but, you know, I could have any number of things, you know. I mean, it's not like looking into, they didn't ask, are you monogamous? Right? That was, you know, and actually, how embarrassing would it be? And, you know, again, to have to correct an assumption is much harder than when someone asks like a neutral question, you know, because then you can answer that. And then when someone says, oh, I don't think you need this, I mean, part of me was like, I don't need it, bye, you know, right? But actually I did. So then it makes it harder in another circumstance to trust the next person, the next nurse that you come into contact with.
Yeah.
To give you the right information. You were going to say something, Stuart.
Yeah, well, I wanted to add in there, and like, and it's really good to clarify as well that you do need it, and it's this medical myth that only penis and vagina sex is where HPV transmission occurs, which is absolutely incorrect. So it's so important that everybody is going for their cervical screens. In the same way as well, we should also be going for all kinds of screens, including for anal cancer or anywhere HPV can spread. But it's also, I think, coming into the fact that we're expected to know these things, especially in relation to LGBT health, specifically trans health, because doctors sometimes have a blind spot, but then again, it's giving too much information or burden, sorry, on the patient. Whereas actually sometimes clinicians are the ones at the forefront of progress in when it comes to medical procedures. So for example, thinking about people who have issues with bladder cancer or prostate cancer and the possibility for nerve sparing procedures. So typically what happens, your prostate gets removed, and then that can obviously create problems with erections, but also can create problems if you're the bottom in anal sex, or also if you're a trans woman. So that point of pleasure can be disrupted. And also if you're a cisgender woman or a trans man, then also it's where your G-spot would be. And what typically happens is, especially because it happens in older age typically, the surgeons will just rip everything out, including the nerves, because they think, well, you know, your life is much more important than your quality of life when it comes to sex. But actually, there have been recent advancements where you can speak to your surgeon and say, can I have a nerve sparing procedure? Is there a possibility? And then that keeps sensitivity, that keeps you having a good quality of life when it comes to sex. But how are we supposed to know that unless we have a conversation with a surgeon? And how many of us can call up a surgeon for a chat? The reality is when you speak to your clinicians, you've usually got 5 minutes tops, and you've got a very narrow view when you're in that appointment. So yeah, I think there has to be way more conversation between patients and clinicians that isn't necessarily just on a patient case, but also just updates from the sector, so we know what we're entitled to.
Mm.
I mean, I think that's massive. We've got two things that have come through on the chat, and I think that being able to access, I think there's a better word, for the right treatment is a major part of this. And I think that a lot of people sort of presume that no matter what, you're going to get the same treatment. And actually, that's what you were saying, that's not the case. So Sue wondered how the nurse felt about the doctor outing her. They had a very funny, close friendship. It was very evident. She had no problem with it. And she was also the one that would come and check on me when she didn't see my partner. She'd be like, are you guys still together? And I was like, you're expecting us to break up? And she goes, we see it a lot, so she kind of made it easy for me to talk to her. They had a very, so I think that, yes, that was totally, it was a very, it was a good environment. So I was very lucky. I was in America at the time, so I was around another doctor, not so nice. And I was around, obviously, like I went to a hospital outside of LA, and I was like, oh my God, I'm in the sticks. Why am I driving so far up the 5 for medical treatments? And, I felt like I was going to drop off the end of the world. And no, I did not let my partner anywhere near me, because I was like, this could be a lot more homophobic. So, and then I've got another really great question. Do you think that the professional could be worried about asking the wrong question? And I was wondering, Charlie, do you have thoughts on that?
That is a good point. I think if you ask just open questions, though, I don't think the question can be wrong. So I think I said in the session about being asked, what contraception do you use? Well, that's that is the wrong question, because you're just asking, you're making a massive assumption there. Whereas, and also assuming that my partner's a man, well, what does he do, or where does he work? And it's like, actually, if you just say they, then that just leaves it open for the person to respond how they want to, and they may continue, they may or may not want to say, but it's, I think, a good open question can't ever really be a wrong question.
Yeah, but it's, I think also, like, so I do work in healthcare, not as a doctor, but and like, we have a lot of questionnaires. So for example, if our doctors are getting patients in for procedures, there's a whole list of questions they have to ask them. And so I think part of it is the service, the hospital, the NHS doing some research as to what are the appropriate questions to ask, and then making a checklist that becomes part of that, taking a patient history checklist. Because actually, for a lot of, not all procedures, but many procedures or many consultations, actually these questions might be relevant. And certainly, like when you're asking about what medications people take, somebody goes, oh, I take PrEP, or I take testosterone, I take estrogen, whatever, you know, you need to take that stuff into account, you know, and you need to have a vague idea, at least a vague idea as to, you know, what those are, why someone might be taking them, and to be able to, you know, have a discussion with your patient as to, okay, you're taking these things, you know, I'm worried that these things might interact with other things that I might have to give you. And, you know, how important to you is it that you continue to take these things? And if it is very important to you, okay, we're going to work together to find the safest way to do that. You know, I think it's like, if you're a medical professional, sometimes you have to ask people embarrassing questions. Like in my role, I have to ask 12-year-olds if they might be pregnant. Okay. You know, that's not an easy question, especially because you have to sort of get them away from their parent or guardian in order to do that. You know, but it has to be done. It's, you know, it's a safety question. And you just have to kind of get over yourself a little bit. It's like, you're asking this for a reason. You're not doing it just because you're nosy. Yeah, you're not just asking the person next to you on the bus. You're asking it for a reason, a professional reason. And, you know, if someone's like, oh, well, why are you asking me that? You should be able to explain and say, look, actually, it's important that I know this because X, Y, Z.
I had a similar situation actually when I was in hospital with my ex, and I was asked to leave the room. And she was just like, well, she doesn't need to leave the room. And they said, no, can you just leave the room for a moment? And they asked her if there was a chance that she could be pregnant, but which I thought actually afterwards, I was like, well, that makes sense to send me out the room, because she's not going to, if she's been having an affair with a man, she's not going to say that in front of me, is she? So I think, you know, at the time it's like, why are you throwing me out the room? And then afterwards, when she said, oh, they asked me if I was pregnant, I was like, oh, okay, that makes sense. So yeah, it can be uncomfortable, but it's, you know, I think there are ways of asking the right questions.
Yeah,
like with that contraception question, she just had to ask, do you have sex with men, before she asked, what type of contraception do you use? You know.
Yeah, absolutely.
Yeah. So I've got a couple of things on the chat here. But before I do that, I do think there is a neutrality also in how you ask a question. I think people sometimes get offended if they think that you presume something. But when there is kind of, just say you bring somebody with you, you know, I'm not saying that this might be a clunky way of saying it, but like, oh, you know, who have you brought with you today? You know, and that person will say, my friend, my partner, you know, however they describe them, instead of, oh, your friend, you know, and it's like, okay, now what do you do? Because now you're in a situation, do you correct them? Now it's awkward, now it's weird, you know, and you just want to get through the meeting. Like, you don't even want to think about this. You want to think about like, okay, well, when's my chemo going to begin? Whereas that kind of openness to a question, there's a neutrality to it. So then people don't feel, I think, you know, don't feel as offended. But so in the chat, it was, that they do think about asking the wrong question. They learned a long time ago not to make assumptions when they mistook a gentleman as a granddad and he was actually the dad. And I imagine like things like that happen quite a lot. And agreeing with Angie on the meds. But I used to say, I'm not sure what that is. Can you help me with understanding more? So yeah, that's a perfect, you know, that openness, it goes a long way, doesn't it? Absolutely. So, we've got one more question from a cancer nurse and psychosexual therapist, people living with a life-changing illness. Sorry, I'm like reading.
Yeah, I can fill in from it. So basically, so it touches on the aspect that awkwardness around sex is everywhere, which is so true. And I think it's a very strange thing, isn't it, where as a culture we find it awkward to talk about sex, and then when you go into treatment, because especially with cancer, it's so much about saving a life that we sort of don't really think then about sex on top. And then it's quite tricky, I think, when you're a queer person, because sometimes the way you have sex is what makes you queer in certain cases. Obviously, there's a cultural point to it, and there's also a science, a sort of social point. And also, if you're trans, then necessarily it won't be the sex you have, it's your identity. But it is part of who we are. And sometimes I know I've been in that position where I'm trying to advocate for that and have those conversations with my clinicians who don't really want to have that conversation. And then there becomes a fatigue of also, okay, well, how do I have to get their attention for this conversation? Do I have to share more personal details? How much deeper do I go? How much more do I open myself to this if it's not really going to be going anywhere? I mean, at one point, they were talking about giving me medication that would give me persistent diarrhea. And then I sleep with men. So I was a bit like, do we have other options? How's that going to work? And their whole thing was like, you'll be fine. You'll be fine. And I'm like, that's not quite what I'm saying. And then also with things like we touched on, I think it was before we started the chat, but things like chemo and how long it stays in your system, and sex and having to use barrier methods. And I asked about that from a sort of anal sex point of view, and I didn't really get an answer. I still haven't had the answer. It's been over a year. So it's those aspects where it's just like, it's very awkward. But I think it comes back to what Angie was saying as well about making sure that there's an understanding of why we're asking, that quite often there can be a clinical relevance, but then there's also a human factor as well, and just getting to know your patient, and whether it's taking other departments' use of language. So psychosexual therapists are really good at this as well. And then also sexual health centers, that idea of passive questions. Okay, what does your sex life look like? What are your partners like? And then that way you can get all that clinical information and note taking you need to do without saying, do you have a husband? Because also people might have multiple partners. They may be a sex worker. There may be multiple things that's going on in their lives that you really do need that information for. And it's best to ask it in a soft way. And that also then means you're less likely to use the wrong words. If you just go in and saying, "Are you gay?" that might make someone go a bit,
Yeah.
And especially if someone is particularly, for example, effeminate in their presentation, it might feel like it was attack. Oh, why are you asking that? Because I'm wearing this jacket or whatever it is. Whereas if you just say, tell me about yourself. Do you have any partners? Who's in your life? What does it look like? And then I think that opens it up a bit.
Yeah.
And actually, you so beautifully said what I was screwing up my eyes to see, which was that this is, especially around sex, is a tough topic, and in the UK to talk about, and further complicated by other diversity, culture, religion, disability, but the psychosexual therapists that you were saying, like, they have so much experience in this area, so they firmly believe it is the health professional's job to ask everyone in a neutral and non-assumptive manner, but hope that a real partnership can be formed.
Yeah, and I also want to add as well, because it's a really good point about disability there, because also for a lot of us, we will acquire some form of disability from treatment. And I think there's not really enough discussion about what sex is like afterwards. And I recently spoke to Isabel White, who's a psychosexual therapist in cancer, and we were talking about this. And Isabel made the really, really good point. We were thinking specifically about bladder cancer, but thinking about that part of getting to know your new normal is almost grieving your old normal and realizing that your life is going to be different moving forwards. And this is just something that we have to acknowledge, grieve, and move forwards. And that process is useful in sex as well. So especially if you're going into a procedure that might change the way you have sex, for example, you're going to have a urostomy bag or a colostomy bag or something like that, it's important to actually go through that grieving period and acknowledge it. And then that's why these conversations can be really helpful, because you can have some good expectation management with your clinicians beforehand. You can get ready, you can get that conversation good inside yourself, share it with the closest people around you, and then prepare yourself, rather than feel like there's no one to talk to with these really intimate things and that you somehow have to pull back from having a sexual life.
And I think that's where also support groups, like places like Shine, it becomes really important to have that space to talk about the different forms of grief, the different strands of relationships and identity, and you know, there needs to be somewhere that you can start to process that. And you know, actually the sex session that is coming up, you know, those spaces often, I know for myself, when I've accessed a bit of support, have been so heteronormative that, you know, sometimes you just feel like, oh, what am I doing here? But, you know, our session is welcome for everybody, and is run by a gay man. And, you know, some of the, I mean, the plus ones, all the sessions at Shine are welcome for everybody. And again, to bring their whole selves, their partners, you know, like plus ones isn't about your other half. It's about whoever is in your life that's supporting you. And I think that kind of openness, that kind of language, that kind of inclusivity really does make a difference. Because, yeah, I mean, you know, people have such wonderfully diverse and interesting arrangements and configurations of their lives, and you know, it's such a tough time. All of that needs to be, you know, have some support. So we have come to the end of our time together today. It's just flown, but I'd love for this conversation to keep going. So if you do have any questions after the fact, you know, feel free to send them into Shine. You know, you can find me. I know I'm coming up under Shine Cancer Support on my thing. I forgot to change my name to Tatum. But you know, on Facebook, on Twitter, like you can reach out to us. Or I think actually, Christopher, you might know this. You can even reach out on this conference, can't you? I think like if you put your bio up. So my name's Tatum, so feel free to send any question that you might have thought about after the fact. And yes, and find Stuart, who runs Live Through This. Thank you.
Well, also, I want to quickly plug the fact that, because we've touched on a few things about not knowing the answers, and we have a trustee board of experts in the field. So if you are a clinician and you're in the point where you're trying to find the answer and you're struggling, get in touch, and we'll use our network across the country to try and get as much of a right steer in the direction as we can.
Yeah, it's brilliant work that you're doing. Thank you so much to Angie, to Charlie, to Stuart, to Scott, who's not here, but to everybody as being a part of this. And thank you to all of you that came along, and thank you for your questions and lovely comments that we've gotten. Thank you. It's been really, really great. And probably see you at a few more sessions coming up this week. I'm so excited. There's so much to do. So we'll see you soon. Thank you.
Thank you.
Thanks.
Thanks.
Bye.